So today we are going to talk about utility and limitations of spirometry in asthma. And our speaker for the webinar would be Dr. S.K. Chabra, sir. And I welcome Dr. Chabra, sir. He does not require any introduction to any pulmonologist. He is looked upon as a boss of Indian pulmonology. Sir is currently working as an HOD and professor head of the Department of Pulmonary Critical Care and Sleep Medicine at Primus Super Speciality Hospital, Delhi. And earlier he was the HOD and head of the department director at VP Chest Institute. I welcome you, sir, to open the session and looking forward for a brilliant and informative talk as usual. And for today's webinar, we'll be having 4 panelists. I mean, one myself, Dr. Indu Bubna from Mumbai. The second panelist is Dr. Shweta Saraf Gargia, who is from Ahmedabad. Our other esteemed panelist is Dr. Abhimanyu Garg from Delhi and Dr. Rahul Ahluwalia from Jaipur. Sir, I welcome you to please start the session.
Thank you, Dr. Bubna, for this nice introduction. So, a very good evening, ladies and gentlemen. We are back at CCI with yet another webinar. I was just talking to Dr. Vijay, and we are almost going to hit the 300 mark. And for an organization to regularly carry out webinars like this every week is undoubtedly a great achievement, possibly good enough to enter the Guinness Book of Records. So today's topic is a very, very practical topic. We'll be discussing how we use spirometry in the management of asthma. So the discussion is not per se on lung function testing or on spirometry. The discussion is more on asthma and how we clinically use spirometry, the different aspects. So for this, we have got a great panel. And as per the CCI practice, we don't go in for, very big names who everybody knows, but we encourage our younger colleagues. And believe me, they're as good as the senior colleagues. And that is what makes the webinars very exciting. So the format of the discussion is that there's a very brief presentation because we will focus mainly on a panel discussion. And then the audience is free to put in their questions that will be sent to us in our chat box, and we'll be addressing those questions. So just to set the ball rolling, I'll just make a very brief presentation on spirometry and the issues that we are going to discuss today. So it's a very brief presentation. So I'm just going to load my slides. Right. So our topic for the day is utility and limitation of spirometry in asthma. So we will discuss how useful it is, where we are unable to get the information that we want, what are the alternatives, how best to use spirometry. There are plenty of questions, day-to-day practice where, everybody who is caring for asthmatics and doing spirometry comes across these issues. Now, a quick word about spirometry. Like I said, it's not a talk on spirometry in detail, but still we have to know a few things before we go ahead. So first thing is that spirometry looks an easy test, but it's a difficult test. The reason is that it requires a great amount of quality control, which starts from your choice of equipment, how you maintain the equipment, the training of the technician. The patient has to be coached in a particular way, and then we all, the physicians, they must know the nitty-gritties of spirometry, how we interpret and how things have evolved over the years. Like in the last few years, there has been so much change in spirometry that it is very important for us to be up to date on how things stand today. So this is a flow volume loop which we get on spirometry. There is also a volume time tracing that appears on the screens in many spirometers with the same maneuver. So you get 2 windows, one volume time and one spirometry. The important point in doing spirometry is that there are 3 areas of the flow volume loop. See, this is flow on the y-axis and volume on the x-axis. So these highlighted areas, these are where the technician has to coach the patient, and there are certain criteria which have to be fulfilled, which are called the acceptability criteria. So this is the start of test. When the patient blows out with maximum force, there's a peak of test, and then there's a smooth exhalation to the end of test. So these three zones are important to focus on by the technician, and the printout that gives the graphs, the physician first has to see that the flow volume loop is acceptable. Only then we go on to interpret spirometry. So a few important concepts in interpretation of spirometry. A spirometry report gives us multiple parameters, but interpretation is based only on three parameters: the force vital capacity, the force expiratory volume in the first, second, and the FUM by FVC ratio. So for interpretation of spirometry, we require only three parameters. We compare these with expected values, what we expect in a person, and these expected values are calculated from what are known as prediction equations. So we calculate predicted values and compare the observed values with the predicted values. The predicted values, they vary by a person's ethnic background. They are different from males and females. They vary with age and height. So when you start your spirometer and then come to the screen for doing the test, the first screen is the patient's demographic data screen, where you enter the ethnicity, gender, age, and height. And then you are also expected to make a choice of equations. So in a software of spirometry, there's a drop-down list where different options are there. The choice of prediction equation is very, very important, because your interpretation can be erroneous if you don't pick up the right equations. So the equations are in the format of the PFT parameter is equal to constant plus a coefficient into age plus a coefficient into height. So we have got our own equations, which I'll be showing in the next slide. So how do we interpret this? Now, our thumb rule is that people take values which are less than 80% are predicted as abnormal, but the guidelines are very clear about this, that this is an error-prone method and is strongly discouraged. What we have to do is we have to compute what is known as the lower limit of normal, and values which are less than lower limit of normal, these are called abnormal. Now, what is the lower limit of normal? We get the predicted value from the equation. Then there is a standard error of estimate which is also available with the equation. So we get a product of 1.645 into standard error of estimate. Whatever we get, we subtract this from the predicted value, and that gives us the lower limit of normal. Now, as far as spirometry is concerned, there is no upper limit of normal. In lung volumes, in diffusion capacity, there are upper limits, but in spirometry, there is no upper limit. We only are concerned with lower limit of normal. So values which are less than lower limit of normal, these are called abnormal. Now, an important point to note is that we are all familiar with the GOLD criteria of airways obstruction. GOLD defines obstruction in COPD as a post-bronchodilator FUM by FVC ratio less than 0.7. Now, this is very important to note that this is only for COPD and not for diagnosis of airways obstruction as such. Right? So this does not apply to asthma. How we diagnose obstruction in asthma, we will be discussing in our today's discussion. Now, this is the format of equations. Now, these equations are available in most of the spirometry softwares. So we have got these in Ganchon, NDD, Pulmo 1. So these equations can be selected from the drop-down list. These are for Indian population, and this is the standard error of estimate that I was mentioning. So for example, for FVC, we'll have a predicted value from this equation, and we'll subtract 1.645 into this number from this value. So that will give us the lower limit of normal. So once we get the lower limit of normal, then we can classify our observed value as normal or abnormal. If we select a wrong prediction equation, and this is something which we must be very, very careful. Very often, we don't pay much attention to what prediction equation we are selecting. If we select, for example, a Caucasian equation, the Heinz equation or GLA equations are available in all softwares. If we select these equations, then there is a big risk of making a wrong diagnosis on spirometry. So our equations must be valid for Indian population. So we use Indian equations. Now, how do we interpret? Like I said, there are only three parameters which are required for interpretation. We have FE1 by FEC ratio, FE1 and FEC, three parameters. So we start with the ratio, and then we compare the ratio with the lower limit of normal. If the ratio is less than lower limit of normal, then we say there is airways obstruction, right? So airways obstruction on spirometry is defined as FE1 by FEC ratio less than lower limit of normal. For COPD, we use a gold definition, which is slightly different from this. So this we must keep in mind that here we are talking about a spirometry result, how to interpret that. Then we look at FVC, whether it is normal or it is reduced. So when obstruction is there and FVC is also reduced, then it is a mixed disorder or there is air trapping. When obstruction is there, FVC is normal, it is a case of pure obstruction. If the ratio is above lower limit of normal, then we say there is no airways obstruction. As we will see in our panel discussion, asthma can be here also, asthma can be here also. So that is what makes discussion on management of asthma challenging, how we use spirometry in this scenario, how we use spirometry in this scenario. So when the ratio is above lower limit of normal and there is no obstruction, if FVC is reduced, then this is suggestive of restriction. We don't use the term restriction only on FVC. Restriction by definition is a reduced total lung capacity. So we only use the term suggestive of restriction on spirometry. When there is no obstruction and spirometry is normal, then FVC is normal, then we say that spirometry is normal. So asthma can come here also. So on spirometry, therefore, we are able to classify physiological patterns. Except for COPD, there's no other disease which is defined on the basis of spirometry. So spirometry only gives us the physiological patterns of disease. So it can be either a normal spirometry or it can be an obstruction. It can be a reduced FVC, which is suggestive of restriction. It can be a mixed disorder, which means combined obstruction and restriction. And then there's, just to complete the pattern, there are certain localized diseases of the upper airways which produce a change in the shape, which we are not discussing today. So in obstructive disorders, asthma is one of the commonest conditions, and that is the focus of discussion today. There are other obstructive disorders also. The next common is COPD. We also get airways obstruction in patients who have got a post-tubercular sequelae, patients who have got bronchiectasis. On the other side of the spectrum are conditions where there's no obstruction, only the FVC is reduced. These are suggestive of restriction, and these are confirmed by either imaging or measurement of lung volumes. So again, we are not discussing these. So our focus today is on asthma. So when we do spirometry in asthma, sometimes we get very useful information, straightway diagnosis established, and we start our treatment. But there are also limitations. So the issues that we are going to discuss today, these will revolve around the diagnosis of asthma. How do we define airways obstruction? How do we measure response to bronchodilator? What is variability of airways obstruction? What is airway hyperresponsiveness? How do we express bronchodilator response? Which parameters to use to evaluate bronchodilator response? Then there's a term called control of asthma. How do we assess control of asthma, and what is the utility of spirometry in assessment of control of asthma? Is spirometry useful as a risk predictor for future adverse outcomes? Goals of management, do they include spirometry? Very often a question is asked, how often spirometry is required to be done in asthmatics? Should we assess bronchodilator responsiveness in every visit? Do we need to withdraw drugs in patients before we do spirometry? What is the concept of personal best? Actually, our topic for the day started with a brief discussion on our CCI group on personal best. And as usual, our team leader, Dr. Krishna, picked up this point that why not discuss spirometry. So the origin of today's discussion is entirely his brainchild. Then severity of asthma. Severity means different things for different people in asthma. How do we use spirometry there? Can spirometry results be used to change treatment of asthma? We are all familiar with step up, step down. So do we use spirometry there? Then a very common mistake often people make is that we try to differentiate asthma from COPD. Is that correct? Can we use spirometry to differentiate asthma from COPD? Then how does spirometry change in special situations like pregnancy, in obesity, in ABPA? Is there any role in acute asthma? So this sets the tone for today's discussion. So we'll move on to our esteemed panel. Dr. Indu has already introduced and we're all waiting and raring to go. So we have got 8 rounds. Hopefully, we'll have enough time to finish these 8 rounds. And if time is left, then certainly all the questions which our audience is going to send, we'll be discussing those questions. So let's begin now. The GINA guidelines, they describe 2 requirements for making a diagnosis of asthma. One is history, and in history, what is most important is variability in symptoms, the intermittency of symptoms, the dynamic nature of the disease. This is part of the definition, right? It's a disease which has wide fluctuations. So lung function varies, the symptoms vary. So good history is very, very important. Second, we have to establish a variability in expiratory airflow limit. So there are different ways in which we can do this. The first point is a good history. The second uses spirometry. Plus there can be other aids also. So we'll start with Dr. Shweta Saraf. Dr. Saraf, sometimes we do spirometry in a patient where we know from history that this is asthma, but the response to bronchodilator is not there. So what could be the reason that there is no response to bronchodilator?
So thank you for the question. So sometimes we fail to see the bronchodilator responsiveness. If there is severe asthma and there has been no permanent damage to the airway, or there is a fixed obstruction, the medication which is being used for seeing the reversibility, it is not being used properly, or the technique is not right, or sometimes it's an asthma mimic, then there are chances that we do not happen to see the bronchodilator responsiveness.
Yeah, but even our asthma diagnosis from history is clear. And like you say, very severe remodeled asthma, there may not be a response to bronchodilator, or the technician has not given the inhaler properly and it hasn't gone in, and then also there will be a negative report. There will be another situation where the patient has responded very well to treatment and he has recovered from the disease, because asthma is a disease which typically fluctuates. So if we test the patient during period of remission, we might find that the patient has a normal lung function. And that is where, when we step down and we go down to step 2 or step 1, and only SOS medication is there. So the point that Dr. Saraf has made is that we can have periods where the bronchodilator response is not there in these patients. Okay.
So also, if I can add, this reversibility is also not seen in exacerbations.
Yes, it is.
The acute response to the bronchodilator.
When we'll have this special situation, there will be discussing whether we can do spirometry at all in an acute situation or not. So there, this will question, but definitely because the patient has to cooperate and do the test properly. So in an acute asthma situation, may not be able to do the test properly. But in any case, the treatment in acute asthma remains bronchodilators. These patients are nebulized again and again.
Yes.
So Dr. Garg, now you put the patient already on treatment based on history, and patient responded very well. So then how do we confirm that patient has a bronchodilator responsiveness? Like we said in the first question, he has responded very well and the lung function has recovered. So that part of bronchodilator responsiveness remains to be established. So how can we establish that? Dr. Garg?
Just unmute yourself.
Thank you for the question, sir. Sir, the patient who has been diagnosed on clinical basis and responded to treatment, if patient has very few symptoms, then we will consider stepping down the treatment.
Right.
Or if after stepping down the treatment, we'll repeat the spirometry at an interval of 2 to 3 months. If the patient has a bronchodilator response or it has a response to the treatment in the form of variability in the airflow limitation, then we can say that the patient has we have made the diagnosis of asthma correctly.
Right. So sometimes we have to uncover responsiveness, and once, because the guidelines have a provision for stepping down treatment once the patient has responded very well. So next is to step down and get down to the minimum level of treatment. So at that time, if we repeat the test, we'll be able to confirm. But a good response to anti-asthma medication is a clinically reliable indicator of the diagnosis. Okay. So Dr. Olivalia, one way of doing bronchodilator responsiveness is to do a spirometry, give a bronchodilator, and after 20 minutes again repeat it and compare the two values. So what are the other ways in which we can establish this variability?
So thank you, sir, for the question. So in such patients, we can always repeat the spirometry measurements. Like we can take the spirometric measurements in the morning or in the evening hours, or also multiple measurements can be done in the day. Also, along with that, we can subject the patient to a methacholine challenge test. Along with that, also some bronchial provocation tests are also there, like cold air challenge and the exercise challenge test. And although the forced expiratory flow 25 to 70% is not included, but that can also be the readings can be taken from the spirometry test and also the PFR monitoring.
Yeah, see, there is one problem with the parameters other than FVC and FV1.
Yes, sir.
There is no standardization of response on F2578. So nothing is specified that how much change would be considered.
Yes.
That is why it is not used as a parameter. The other thing, besides challenging the patient and showing variability, we can compare their lung function over a long time.
Yes.
Supposing we do the test now, after 3 months again do it, then the pre-bronchodilator test on the two occasions can also differ. So that's a long-term variability. Yes. So the idea is to show that the airways are hyper-responsive. They fluctuate in their definition, in their airways obstruction. So that can be done acutely by giving a bronchodilator or repeating the test after some time. So if you have 8 or 10 reports in an asthmatic, you'll find that there's a lot of variability in their pre-bronchodilator status. So that is another way of establishing the variability, and these are well documented in the GINA guidelines.
Yes.
So Dr. Bubna, again coming on the question of variability, is peak flow meter useful in documenting variability in expiratory airflow?
So, sir, basically in resource limited setting where spirometry is not available, we can use the peak flow meter. Though it is less reliable, but then it is better than having no objective measurement of the lung function. So, one thing when we use the peak flow meter, same meter should be used every time because there is a difference of up to 20% with different meters. And when you're using the peak expiratory flow, the highest of the three readings should be used for the diurnal variability. Now, basically, what is variability? It is basically improvement or the deterioration in the lung functions. And excessive variability is an essential component in the diagnosis of asthma. And this excessive variability can be actually measured over the course of one day, which is called as diurnal variability, or over the course of weeks on the ICS containing regimen, like 4 weeks. And then during the visits, between the visits also it can be checked, and by the bronchial challenge test. So if I tell you in numbers, then the peak expiratory flow readings, if you want to check the bronchodilator reversibility, then the peak expiratory flows increase from the baseline of more than 20% is considered as a reversibility. And average diurnal variability from of more than 10% is in the adults is taken as excessive variability in asthma. So during the visits also, if we are seeing the variation of more than 20% in the peak expiratory flow, that is again considered as excessive variability. And bronchial provocation test actually tells us about the deterioration in the peak expiratory flows. So if the deterioration in the peak expiratory flow in children is more than 15%, then again it shows excessive variability. Yeah. So any of the one of these things, if they are positive and if the clinical symptoms are suggestive of asthma, then it goes in favor. There is a high probability that it is asthma. Yes. So basically, So basically, Gina emphasizes that when we see the variability and excess, more number of the times the excess variability is seen, then there is a high confidence that we are going in favor of asthma.
Asthma. Yeah, sometimes, you have patients, you do spirometry, every time it comes normal. But history suggests in such a scenario, use of a peak flow meter may uncover variability, and we can give them a meter to use at home so that this variability can be established.
So they can measure the serial peak.
Like you say, variability is the second part of the diagnosis. One is history, and a good history establishes a working diagnosis. In fact, the GINA is very clear that you can start treatment on the basis of history also if you are very confident, but confirming variability, and like all my panelists have given their inputs, that either short-term, long-term, using spirometry or variability or by challenge test, whichever way you can show that the airway caliber fluctuates over periods of time. In fact, if you look at the definition of asthma by SCADing, that was the original definition before GINA came. So that definition is a wide variability in airflow over time. So that is what is diagnostic of asthma, and that we have to document to confirm.
Also, Gina mentions that there should be one documentation of the airflow limitations. So the FEV1, FVC of less than lower limit of the normal, at least on one occasion, it should be documented.
Absolutely. So we should not lose heart that spirometry is normal or the response is not there. We have to devise our methods how to pick up this variability. Yes. So once we know, and that is what we have discussed in this round of questions. So we move forward. Now, we have been talking about variability and the bronchodilator response. The recent statement of the ATS ERS in 2021, they have come up with a different idea about expression of bronchodilator response. They say that you measure the change after giving bronchodilator, the post minus pre, and express this as a percentage of predicted value. Now, this is as such not a new technique, because this technique has been around for more than 20 years, but now they say, and this is much different from what is recommended in the 2005 guidelines. So this is a new method which our softwares at the moment don't allow to be used. So Dr. Saraf, if we look at the different ways in which we can express bronchodilator response, What was the previous one in 2005 interpretation guidelines and the current one? What is the difference between that?
Sir, actually, we have to see how much inhaled bronchodilator improve the airflow or the volume. So the percentage change in the FEV1, if it is more than 12% or in lead volume it is more than 200 ml, then it is considered to be a good response to the bronchodilator.
Yes.
In 2021, the ATS ARS also mentions that we have to say the relative changes to the predicted normal values. Sometimes what happens in children, even though the change is more than 200 ml, but if we see the percentage, it may be less than 10% also. So if it is, if we are getting a bronchodilator response of more than 200 ml, then we can consider it to be having a good BDR response.
So, Dr. Garg, these methods, so what are the advantages and disadvantages? Can we straight away start using the change as a percent of predicted value? What is the limitation in that method? 12% 200 ml, this is what everybody is using at present.
So the point is the change, the earlier changes that may not be that may not be clinically relevant. The patients who are having a change of more than 12% or 200 ml in FE1 or FBC
12% and 200 ml.
and 200 ml, so that could not be clinically relevant. But the patients, there is another criteria in which we see the threshold at which the clinical manifestation occurs. So it gives an idea about the, sir, there is some idea about the survival benefit. If it has a predicted value of more than 8% or more than 10%, they might give an idea about the predictive value of the survival. That is why they are better
Only
in terms.
difference, even the ATS, is that this change as a percent of predicted value, this may be better in expressing long-term mortality in these patients.
Yes.
Yeah.
But as far as the clinical application is concerned, because you require predicted value for this. So your choice of predicted value will determine the positivity. Your response expressed as a percentage of predicted value may be positive by one predicted value, may be negative by another predicted value. So that is a limitation, that you have to select the right predicted value. So,
Sir, if I can add one point over here.
yeah.
As you asked, what are the limitations of using this 10% of the predicted value? I think it will underdiagnose asthma patients and overdiagnose COPD. If you are using this value, that is why Gina probably doesn't recommend.
No,
So,
the COPD doesn't come in here, because in COPD, that bronchodilator response is not a diagnostic criteria.
Yes, sir. Yes,
Right? So
sir.
that is not an issue here.
Yeah.
But whether the older definition of 12% and 200 ml should be substituted by this, that is the issue.
So I wanted to add that probably Gina is still not advocating it, because that 10% thing will probably underdiagnose asthma if you are using the 10% value.
Yeah, because 200 ml may not be 10% in
Yes, sir.
larger lung. So, like you rightly say, that Gina still advocates going by the 2005 guidelines, that is 12% and 200 ml. So it has not yet advised switching over to the ATS ERS 2021 guidelines. So we continue to use 12% and 200 ml, change in FVC or FE1 to express bronchodilator response. So Dr. Ahluwalia, in the PFT reports that you see, how is the bronchodilator response expressed?
So, sir, it is expressed in two ways. One is
In the
in the
reports that you
actual.
have seen, in your report.
Yes, sir. So we always see the bronchodilator response in we see the absolute change in the
No, you're not getting my question. You have a
Sir.
report in front of you, printed report.
Yes, sir.
What does the software show?
So it shows we look for either 200 ml change and 12% change in the percentage of the FE1, sir.
Right. So, no, what I'm saying is that in the columns that you get in the report, you only have the last column as percentage change.
Yes, sir.
Right. So the report
Yes, sir.
is not designed to give you information on the bronchodilator response.
Yes, sir.
Whichever spirometer machine you choose, whichever report you see, the last column is percentage change.
Yes, sir.
Whether there is a difference, that you have to compare
Yes.
and see what is the difference.
Yes, sir.
Decide whether
We have to manually do it and get to the.
The point I am trying to point out is that our softwares are not yet ready to implement the ATS ERS recommendation of change as a percent of predicted value. So even if you want to use that, maybe for research purpose, you will have to compute that yourself manually.
Yes, sir.
So the consensus is, and as the Gina says, that for bronchodilator response, we continue to use the 12% and 200 ml change in FE1 or FVC. That again is a very important issue which we are going to discuss, because when we talk of which parameter to select for assessing the bronchodilator response, because FE1 can also change, FVC can also change, right? So the ATS recommendation in 2005 said 12% and 200 ml increase in FVC or FEV1. The word used there is or.
And so that was from the baseline.
Yes, 5% is always over the baseline.
And now it is from the predicted value.
That Gina has not accepted yet.
Which is not accepted.
That is only a proposed thing, and that is still under evaluation, right? So Dr. Saraf, which parameters can be used? What are the recommendations? You know, we have, besides this, like there was a discussion of F20 or 75 also, PEFR also. So what do the guidelines say? Which parameters to use to measure bronchodilator response?
So the guideline mainly mentions that FEV1 FVC ratio should be seen. One value should be documented of low LLN. Apart from it, we have to see the FEV1 values, the FVC values, even the FEF 25 to 75.
First question is a little different. To assess bronchodilator response, which parameters we have to, we can choose?
So, FEV1 and FVC ratio, FVC are the two parameters which are to be seen for the bronchodilator response. It also mentions that sometimes FEF 25 to 75 can also be used to see the response of BDF.
Yeah, the only problem there is that it has a lot of variability and there is no standard definition of what is a bronchodilator response when F25-75 is being. What about FE/FVC ratio to measure bronchodilator response?
So there, like the guideline is not that very clear, but it is saying that if FEV1 and FVC ratio is normal, then COPD should be rolled out. And
no, that is a different aspect. Measuring bronchodilator response, let me make things clear. You have done spirometry your pre-bronchodilator data FE/FVC ratio is, let's say, 65%. Post is also 65%.
Okay.
But FE1 and FVC both have improved.
So if so the ratio is below LLN and both of them are included, so it tells us that it's a case of asthma if the change is more than 12% in 200 ml.
Let me elaborate that. See, basically we don't use FE/FVC ratio to express bronchodilator response. The ATS ERS guideline 2005 very clear that 12% and 200 ml in FVC or FEV1. No other parameter. Only these two parameters are to be used to measure bronchodilator response. So, Dr. Garg, which one you think is going to give better information, FVC or FEV1? In your experience, what do you find?
We usually use FEV1, and whichever we are getting the better one in terms of the guidelines. If we are getting FVC that is accepted as per the guideline, we use that.
But both can change, no? FVC can also change, FEV1 can also change.
Yes, sir. So, like FE1, we can find it more handy, or we can say we use more frequently the FE1.
No, in a report, if FE1 has improved,
yes, sir,
FVC has not improved. So you will take it as a response.
Yes, sir.
If FVC has improved, FEV1 has not improved, that will also be response.
Yes, sir. So
Either way, no?
either we can use both.
So, Dr. Ahluwalia, so are we getting the same kind of information from FEV1 and FVC on bronchodilator response, or is it something different that we are getting from FVC and FEV1?
So, sir, they both represent and indicate towards different things. Like FE1 is always suggestive about the large airways condition and probability obstruction, and they don't give much information about the small airways. Whereas the FVC assesses the lung volume and also indicates about the restrictive patterns, but they are not, FVC is not able to give us the information about the degree of obstruction or about any specific airway like small airways.
Again, let me elaborate this further. See, when we give bronchodilator to either COPD patients or asthma patients, we can have three kinds of responses. One is called a flow response, the other is called a volume response, and they are double or dual responses. So flow responders are those where FE1 improves. Volume responders are those where FVC improves. And this is a marker of air trapping and hyperinflation.
Yes.
And in fact, in COPD, the volume response is fairly common. You know, this old concept that COPD doesn't show bronchial response is now given up. So COPD patients respond very well, and they predominantly respond by volume response. Whereas there are asthmatics who will have both flow and volume response. So that is why the ATS 2005 guidelines say that you can have a response either in FVC or in FEV1. So whichever is giving you the response. If the response is in FE1, we say it's a flow response. If the response is in FVC, we say it is a volume response.
Also, sir, I would like to add, if the FVC improves more than FEV1, then it suggests small airway obstruction because the air is coming out from the small airways. So it suggests early COPD, probably, you know.
So that can happen in asthma as well. And FEV1 also tells you about the small airways. So FEV1 is a broad parameter. Dr. Bhuvnath, since you have come in this question, and the next question was for you in any case. So, is the pattern of response different in patients with COPD?
Yes, I would say so. Lung function is essential for the measurement of the persistent airflow obstruction, which is seen in COPD. And variable airflow limitation is basically seen by serial measurements, peak expiratory flow measurements, and before and after the bronchodilator.
What about bronchodilator response in COPD? What kind of bronchodilator response they show?
Yes. So in COPD also we can see the reversibility, which is 12% and 200 ml. There is a subset of the COPD patients where we see reversibility when the FEV1 is low. And there are severe asthmatics which don't show the reversibility because of the...
In COPD, what is the pattern of response? Is it...
Yeah, that's what I'm saying.
Volume response or flow response, which is more common?
In COPD, there is a basically...
The volume, see,
volume
there's a lot of air trapping in COPD patients, and that is what improves.
FVC,
yes. So FV response is very common in COPD patients, and that is why
I would put it like that the excessive variability what we see is not seen in COPD. While
variability is a different thing. That is a part. The flow, because pathologically we are looking at a different site of disease in COPD and in severe asthma, and where there is distal airways which are opening up, so there is a volume response.
FVC will
improve. So that happens both in severe asthma as well as in COPD. So, Dr. Saraf, when we treat asthmatics, then we have to assess control of asthma, right? How the patient is responding. So does spirometry have any role in assessment of control of asthma?
Yes, sir. Spirometry plays a significant role in assessing the asthma control. It gives us an objective measurement of the lung function, which help us to monitor whether the patient is how much the patient is having the effectiveness of the treatment, or what is the reversibility either the asthma is getting poorly controlled, whether we need to step up the treatment or we need to step down the
Dr. Sarah, what is the GINA guidelines say about using spirometry in assessing control of asthma?
Sir, GINA guideline does not include the spirometry for assessing the
Exactly.
step up and step down. But yeah, it mentions there are only 5 criteria: whether the patient is having any nocturnal symptoms, daytime symptoms, or there is any need of the extra doses of the inhalers. So GINA guidelines does not tell about the spirometry use.
So as per GINA guidelines, spirometry does not have a role in assessment of control of asthma.
Yeah.
But are there any other control measuring instruments where spirometry is used? You can have these formal questionnaires, like if you use ACT, asthma control test, there
Asthma ACT
spirometry is not used. If you use asthma control questionnaire, then spirometry is one of the questions. So depending
Yes,
on
there is one value.
Yeah.
There is one value in asthma.
right, control questionnaire. So ACQ use. So depending on which instrument you are going to assess control. So in the GINA guidelines, it is only symptom assessment, and you can step up treatment based on symptom analysis. But if you're using ACQ, then spirometry is required there. So it depends on how you are assessing control of asthma. So, Dr. Garg, we had some reference to stepping up and stepping down. So, can spirometry be used to step up treatment and step down treatment?
So, in stepping up, we do not require spirometry.
Right.
As per the guidelines. When stepping down, we should test the lung function. So in stepping down, that should be conducted to assess the lung function, because the FE1 in which the patients, they have less than 60%, they are at a higher risk of mortality as per one of the risk factors of the acute exacerbation of asthma. Sir.
Right. So that is made a very good observation that stepping up we can do on the basis of symptom. That is what the GINA says. But stepping down, GINA says that you must be meeting the goals of asthma treatment before you de-escalate treatment. Otherwise, the patient is going to have an exacerbation again. So your lung function must improve to near normal before you start stepping down. So that is an important point, that we don't step down treatment unless spirometry has become normal. Dr. Ahluwalia, is serial spirometry useful in the management of asthma?
Yes, sir.
On doing it again and again many times. So in which kind of patients that will be useful? Because like we were discussing stepping up treatment, there
Yes, sir.
GINA also says that you only use the symptom control. So
Yes,
serial
sir.
testing is not required. You can go from step 2 to step 3 to step 4, step 5 on symptoms.
Yes, sir.
But which patients will use spirometry again and again?
So, sir, serial spirometry can help in the patients to monitor the control, also to assess the response to the given treatment, to detect any exacerbation in its earlier phase, and also it helps us in engaging the patient in his own treatment.
Yeah, that is one-time involvement.
Yes.
When the patient comes to you and you want to increase the treatment level,
Yes, sir.
so will you go in for a spirometry?
So, sir, serial spirometry, they help in patients if the patient is coming to our OPD and if the symptoms are suggestive of asthma, and if the spirometry at that point is normal. So, if we keep the patient in our close follow-up and keep a track on the serial spirometry, it always helps us in the detection of any airway hyperresponsiveness.
We discussed that in diagnosis.
Yes, sir.
Eventually,
Yes, sir.
reversible obstruction will come up. No, but once
Yes,
the patient is put on treatment, let's say you put the patient on step 3 treatment,
Sir.
and the patient not well controlled, you want to go on to step 4. So, will you do a spirometry? Is it?
No, sir.
Won't use.
We'll always go clinical, and then we can always step up the treatment without the help of spirometry.
Yes, so that is what Gina advocates, that it's a symptom
Yes.
analysis, and the definition of control of asthma in Gina, whether it is uncontrolled, partially controlled, or totally controlled, is based on symptom analysis. But again, like we were discussing in the previous question, there is a control measurement tool called asthma control questionnaire. That also you can classify a patient to totally controlled, well controlled, uncontrolled. So their spirometry is used. So again, plus there are some patients who are very poor perceivers of asthma. You know, they have lots of bronchi and airway, but they feel that they are perfectly normal. So in these patients, you will not step up because they will not complain of any symptoms. So those who are poor perceivers of symptoms, again, spirometry is an objective way of showing that there is actually a problem in these patients. So any inputs on serial testing from the panel before we move on further?
In occupational asthma also we can do the serial spirometry. When the patient comes to the clinic, probably he is normal.
Exactly. Yeah. On days, off
And
days.
also, yes, and also patient when they are having values above the normal range, you know. So on the spirometry, we may think it is normal, but the serial spirometry, when it falls, then we can understand that the patient is having.
Yes, that is what we discussed when we were discussing diagnosis.
Personal best.
6-7 spirometry report, they will show a lot of variation, so that establishes the diagnosis. So, Dr. Bubna, sometimes we see a patient who has a normal looking spirometry. The values are in the normal range, but they still are response to bronchodilator. How do we interpret this kind of report?
So, one instance, yes, sir. One instance is where the patient is doing the spirometry for the first time. So he may be having a lower value, and then later he might be having a higher value. So that reversibility, what we see is basically the learning effect. It's an artifact. It's a false bronchodilator reversibility. So we may not interpret that result.
Even if the report is normal, I'm saying.
Yes, but the reversibility component, yes, sir. So that reversibility component is a false reversibility, and we may that's an artifact. It's a learning effect, basically.
Right.
And the second instance is the values which are taken above 80% as a normal value is not recommended by the GINA. So there is a wide range of normal values around the predicted value. So anything which is below 1.645 is basically below the lower limit of the normal of the predicted value. So anything which is below minus 1.645 is abnormal, and anything above 1.645 is normal. And there is no upper limit in spirometry. So basically, a person might be having an FEV1 of, let's say, 120%. And when he comes to us, his values may be 80%. So we might think that the report or the values are normal, but the values are basically low for his personal best.
So this is a very, very important point that you have made, that the predicted values are not just single value, they are only the 50th percentile.
Yes.
And the range of normalcy is wide. So patient can have, like you gave the example of 120% before he got symptoms. Now it has fallen down to 90%. So that's a 30% fall in lung function for that patient. So that's a substantial fall. But both the values are within normal limits.
Yes.
So
when we
response therefore establishes the diagnosis. This is truly an asthma patient.
Yes. And also when we see FVC and FEV1 both responding to the bronchodilator, that is a true bronchodilator reversibility in these kind of patients.
Right. So these limitations one must know, that having a normal or apparently normal spirometry does not mean that there is no airways obstruction. Patient can still have obstruction because we don't know what was his previous best value. So with treatment only we can establish that. So Dr. Saraf, if we do tests, and spirometry is something which can be done several times over 5-7 years, patient may have 3 or 4 or 5 spirometries or even more. So is the bronchodilator response required to be assessed every time? Or we do only a free bronchodilator response?
So every time we don't need to assess for the reversibility testing. If we need to, like, if the patient is on treatment from a long period of time and we need to look for the reversibility testing, then we have to ask the patient to stop the bronchodilator for, like, depending on the inhaler, what the patient is taking, whether it is a short.
The question is different. Do we need to do the bronchodilator
So
response?
we don't need to do it every time. Generally, for the very first time when we are suspecting it to be an asthma and we want to differentiate whether this obstructive airway disease is, whether it is an COPD or asthma or any other obstructive airway disease, then that very first time reversibility test is very much important. But in the subsequent testing, it is not always necessary to go for reversibility testing.
Yeah, exactly. So we don't have to do the bronchodilator response again and again once your diagnosis is established, because the purpose of doing a bronchodilator response test is to show that there is a variation in expiratory airflow.
So I would just
that
like
is met, then there's no point in doing the test, because doing bronchodilator response involves resources. You have to do the test twice. It's tiring for the patient also, and no useful information because your diagnosis is already established.
Yes.
You wanted to say something, Dr. Bobna, on this?
No, actually, I would just like to correct Dr. Shweta. I think you mentioned that bronchodilator reversibility should be done at the diagnosis to differentiate between COPD. So
that will
basically,
come to later.
yes,
Right?
sir. Yeah, you noticed that.
Yeah. So, Dr. Garg, what about stopping drugs before spirometry? Patients' first spirometry and patients' any other subsequent spirometry, is drug withdrawal necessary?
So for the first time, if we want to make a diagnosis, if the patient has very less or low symptoms, or we can say less frequent symptoms, then we can make an attempt to stop the bronchodilators to see for a response or bronchodilator response. And when we are following up a patient who is on current treatment, we should not withdraw the drugs before spirometry.
Yeah, so that's a very important point. See, when the patient is being tested for the first time, where you don't have the diagnosis, so you want to see how the airways respond to a bronchodilator. So you give the bronchodilator and do the test as we have discussed earlier. But once the patient is on treatment, then asking the patient to stop the drugs before coming for the testing, that serves no purpose, because the diagnosis is already established and you actually want to see what is the best level of lung function the patient gets while on treatment. So it's always better to let the patient take his morning dose and then do the test to see whether there is still further scope for improvement or not, or whether he has reached the best. So drug withdrawal is therefore not necessary for these patients once the diagnosis is established, and we can do the testing even when the patient has taken the morning dose. So Dr. Aluwalia, we have been discussing the wide range and how the test may be normal but improve after bronchodilator. So there's a term which Gina uses, personal best. So can you elaborate on this concept of what is personal best?
So basically, sir, over a period of time, it has been realized that by not going on to the predictive values, we should always focus on the personal best of a patient. Since the personal best is coined as the highest recorded value for the patient over a period of time, it helps in assessing to monitor the lung function, also to assess the control, and also for early detection of any reduced lung functions. And it is very important in adjusting the medication if needed, also to prevent exacerbation and improve the awareness about the same thing to the patient so that his compliance gets better over a period of time. So in the serial spirometry, it is very important. We should know the personal best of each patient so that he can be subjected to an individualized treatment.
Right. So personal best provides firstly the information on optimum treatment, that we are given the best possible treatment. What is the maximum improvement that we can get in the particular patient? This will also help in picking up patients who have got a partially reversible disease, that they never become normal. So they have got a airway remodeling. And in fact, if we are dealing with a very severe asthmatic, and we'll find that their personal best is still way below normal, and this helps in deciding whether these are patients for biologicals,
Yes, sir.
because they are not improving with the standard pharmacological treatment. So personal best is something which we must strive to establish in all patients, and this would require serial testing, baseline testing, then the best possible treatment, and ideally when the patient is in remission, then we check where the best. And like we say, there's no upper limit of normal, so we can have a value which is crossing 100%. So there's nothing sacrosanct about 100% value. It can be more than that. So, Dr. Bubna, in your practice, and this is a question which even Gina hasn't really addressed, how frequently should spirometry be carried out?
Yes, sir. So as you said, there is no hard and fast rule, and Gina has not specified on that. But it depends on what you are seeking from the test. So it's an individualized decision. And Gina recommends that test should be done at the start of the treatment, before we start the treatment, basically to assess the variability. So that documentation of that variability should be there, the bronchodilator reversibility.
Right.
Then it can be done 3 to 6 monthly on the ICS containing treatment to check for the patient's personal best value.
Right.
And then periodically to look for the ongoing risk assessment, basically for the future risk of the adverse events like exacerbations, or to look for the persistent airflow
And this
limitation.
would always be only a single spirometry, no bronchodilator response there.
No bronchodilator response.
Yeah,
Yes,
so
sir.
natural history is important to establish. Although natural history of asthma is not always one of worsening. In fact, patients may go into long-term remission also. But some
Yes.
patients who have got a poor lung function, they may have a faster decline. So to pick up those patients, that is where spirometry is useful, and this can be carried out in such patients. So, Dr. Saraf, we talked about quality control in one of the earlier slides, acceptability criteria, and then there's also repeatability criteria, that if you do spirometry 3 times, then FVC and FE1 both should agree within 150 ml 3 trials. So that is the repeatability criteria. So, is it possible any scenario where an asthmatic fails to meet these repeatability criteria, that acceptability criteria is met, repeatability is not met? Dr. Saraf?
So there are certain conditions in which this repeatability criteria it fails. In case there is severe asthma, then there are chances that it will fail, or if there has been some issues with the calibration, or the temperature difference between the machine and the environmental changes are more, then also there are chances of failure of the repeatability criteria. Sometimes there is a loose connection that will also lead to that may also lead to failure in the repeatability criteria.
These are technical flaws, but once we have got an acceptable spirometry, sometimes repeatability criteria is not. In fact, in very severe asthmatics, we see that each successive effort leads to a lower FE1 and FVC.
FEV1.
And that is the impact of a deep inspiration. There's a reflex that when we take a deep inspiration in spirometry, it leads to bronchoconstriction. So the first one is usually the best effort that patient has given. We repeat the second one after 3 to 5 minutes, the values are lower. We again repeat it, the values are lower. So they never have that repeatability, but all the trials are acceptable. So only the first one is the best one. So this does happen. So we should not reject this session that patient is not meeting the repeatability criteria. We can make a note on the report that the repeatability criteria has not been met, but acceptability criteria is met, and the clinically useful information is available. So the individual judgment can be applied in these cases. Dr. Garg, we know how airway obstruction is defined in general, and GOLD gives a 70% cutoff post-bronchial to define airways obstruction and diagnose COPD. Is there any valid way of defining airways obstruction in asthma? When do we say that there is airways obstruction?
Now, the current new guidelines, the GINA, they recommend there is a Z score, that is the values which are lower fall within the lower limit of normal, that is below the fifth percentile of the normal individuals. Whenever we have a value that is below the lower limit of normal, we can define the obstruction.
Which parameter? Which parameter?
So FE1.
Or the ratio?
Sorry, ratio of the FE1 and FBC that is below the lower limit of normal. That signifies obstruction.
Right. So the statistically valid way is FEN by FEC ratio less than lower limit of normal. But GINA does mention somewhere 80%, 85%, 75%. So these arbitrary cutoffs are still mentioned in GINA, but so that creates a lot of confusion that what is airways obstruction. So one way where there is no doubt is to define by lower limit of normal, and that is what the ATS ERS guidelines say, that the FEN by FEC ratio. In fact, the interpretation algorithm in 2021 and also in the 2005 guidelines that clearly says that FEN by FEC ratio less than lower limit of normal defines airways obstruction. In fact, in COPD also this debate is always there in each GOLD guideline. If you see this section on defining airways obstruction, and then they settle for 70% because they say it's a practical way of defining airways obstruction. But the correct way, and in asthma, because that 70% rule does not apply, so one has to go by the lower limit of normal. So which again means that your choice of prediction equation is important, because the lower limit of normal will depend on what is the prediction equation that one has selected. So Dr. Ahluwalia, when we start treatment of an asthmatic, then we have certain goals of treatment. So as far as the lung function and spirometry is concerned, what is the goal of treatment in asthma?
So basically, sir, we can divide it into 5 points, as in to achieve optimal lung functions of the patient. That is, if the FEV1 values are more than equal to 80% of the predicted, and minimize airflow obstruction. That is to increase the ratio of FEV1 by FVC, prevent airway remodeling. That is to minimize long-term FEV1 decline, and to reduce variability in lung function. That is to have a goal of having a stable PFR and FEV1 readings, and also to prevent any exacerbation. The stability of the readings of the FEV1 reading.
Clinical goals. So lung function goals are that we try to get normal or near normal lung function, and that is our objective of treatment. And again, to differentiate from the goals of management in COPD, there is no mention of how much improvement we are expecting in lung function. So the goals of treatment in asthma are different from goals of treatment in COPD. In COPD goals, there is no mention of lung function improvement. So to get normal or near normal lung function testing, that is the goal. So Dr. Bubna, what about spirometry as a future risk predictor? We had some discussion. So can you further elaborate what are the future risks which can be predicted from a bad FEV1?
So lung function is an informative predictor for the future risk of the adverse events. So if the FEV1 is less than 60% of the predicted value, then it is a modifiable risk factor for the exacerbation, future exacerbation, besides being a risk factor for severe persistent airflow limitation. So definitely we can predict. So we should do the serial spirometry to find out the risk of the future adverse events. And to also it tells us about the faster decline in the lung function, sir.
And a predictor of future mortality.
Future mortality. So that is why yes, in the epidemiological studies, it is said that, the lesser the FVC values, the lesser is your life expectancy. And there is a, early cardiac event risk is also there. So lung functions are an important predictor.
Right. So that is why when we think of giving biologicals to these patients, a poor lung function is one of the inclusion criteria for such patients, that these are the patients who may benefit from use of biological because they are not responding to the standard pharmacological treatment. So Dr. Saraf, some special situations in children, there's a normal spirometry, and the parents say that when the child runs, he gets wheezing and breathlessness. But spirometry is normal. So how do we confirm the diagnosis in such a situation? The only trigger is that on running in school, the child is playing, gets wheezing on running.
So this can be an exercise-induced asthma.
Right.
So to confirm whether it is an exercise-induced asthma, we have to do an exercise challenge test, which is either done on a treadmill or on a static bicycle. So there are set protocol for the exercises which are being achieved by either asking the child to do some kind of physical activity, either on the treadmill, on the cycle. And when the heart rate reaches to that level, then a series of spirometry is being performed to see whether there is any drop in the FEV1, spirometry changes in the FEV1 or FEC levels. Apart from the exercises, there can be other tests also which can be performed to get the stress, like methacholine challenge test or the mannitol or the hypertonic saline test. But the most common is the exercise challenge test.
Right. So, supposing we talk about a more practical situation, you don't have access to a treadmill or exercise cycle, and methacholine challenge is out of question. Then, how do you test exercise-induced asthma in a routine clinic?
So it can be done outside the clinic also. We can ask the patient to do some kind of physical activity like jumping, or if we have an access to a lane outside, we can also ask to cycle or to run, and then perform the spirometry test.
Right. So that is the practical way out, and especially in cold and dry air, exercise induces bronchoconstriction. It may not happen when the weather is warm and humid. In fact, it would be a little difficult to get a positive exercise challenge test in open air in Mumbai as compared to Delhi, because warm, humid air has a protective effect. So cold, dry air, that induces bronchoconstriction, and that can be used. Of course, a formal exercise challenge test like you have described, a 10% fall after exercise. And this is a very important point that you have made, that exercise-induced asthma is not dyspnea on exertion. It is a post-exertional dyspnea, that the child has done the exertion, he has stopped, then bronchospasm starts developing. Dyspnea on exertion, like happens in COPD, is the moment the patient undertakes any kind of exertion, he gets breathless. Right? So this is a clear distinction between dyspnea on exertion and exercise-induced asthma.
So, sir, also like you gave an example of child, having bronchospasm. So we can use a peak flow meter, tell them to use a peak flow meter, and if the fall in the peak flows in children is more than 15% of the predicted value from the baseline, basically.
Yes. Yes, exactly. So that is useful.
Yes, sir.
So Dr. Garg, there is a condition, cough variant asthma, where everything resembles the classical asthma except that there is no wheezing and no dyspnea. So is spirometry useful in diagnosis of cough variant asthma?
So when we are suspecting cough variant, if spirometry comes out normal and we are not getting any alternative diagnosis for cough, like we have ruled out GIRD, sinusitis and other causes, then there is an indication that we can perform a test for airway hyperresponsiveness to see
in practical scenario.
Practically,
normally people would have facility for a methacholine challenge, right? So let's talk a practical thing which everyone can do in his clinic.
Practically, we give ICS, we give inhaled corticosteroids with a LAVA combination. Then if patient responds, then we say it's a cough variant asthma.
Any other test that you can do? Although we are not discussing beyond spirometry.
So,
FOT is a
FOT can be tried, and we can pick up small levels of obstruction there, and even a bronchodilator response. That is one of the situations where FO2 may be useful in management of asthma. Dr. Bobna, you want to come in?
Yes, sir. I wanted to add, if not like FOT, if you are not using FOT, then probably cough variant asthma can be diagnosed like when you are stopping the ICS containing treatment and the patient again has the same symptoms, then we can.
In a practical scenario, the drug response is very, very important. In fact, cardiologists use it all the time. The sublingual sorbitol, that's a sure confirmation that it is angina. So use of steroid and good response establishes the diagnosis of airway hyperactivity and covariant asthma. So Dr. Ahluwalia, we have discussed about the spirometry in normal range. So if it is coming normal, then one way, of course, is stepping down the treatment once the patient has recovered. But theoretically, another way of confirming the diagnosis in a normal spirometry.
In a normal spirometry, sir, we confirm the diagnosis. We need to probably go on to additional tests to make the confirmation, like PFM monitoring. Any methacholine challenge test can be done, but now obsolete. Pheno measurement we can do, and if the history also suggests, we can subject the patient to an exercise challenge test, and also clinical reassessment is very necessary by keeping the patient in a close follow-up and then repeatedly taking the history and also the probably repeating that serial spirometries.
Right. So you clearly point out that there's more to making a diagnosis of asthma than just spirometry. And if your history is very suggestive, we must examine all possible ways of establishing that this is asthma. And pheno, if it is high, that is an indirect way of establishing the diagnosis. We have discussed earlier that giving treatment and seeing the response is a way out. Challenge is a theoretical test. Peak flow variability, as Dr. Bubna has said, and FOT is another way that diagnosis can be established. So, Dr. Bubna, there was some discussion on differentiating from COPD. So, what is the present position on asthma versus COPD and differentiation by spirometry? Because once upon a time, COPD was called an irreversible airway disease, asthma was called a reversible airway disease. Yeah. So, is this test of any use in separating asthma from COPD?
So basically that reversibility criteria is no longer used to differentiate between asthma and COPD, because in severe asthmatics, we don't see the reversibility because of the airway remodeling and air trapping, while in a subset of the COPD patients, we see a good reversibility. So that reversibility criteria is now out to differentiate between asthma and COPD. And of course, spirometry alone should not be used to establish a diagnosis of asthma. Rather, it should always be used to support and confirm the clinical suspicion of asthma. And also, if you're talking about the reversibility, like I earlier mentioned, the reversibility seen in both, but the excess reversibility, which is 14% and 400 ml, that is only seen in asthma, which is which is unusual in COPD.
If you look at GOLD, the GOLD does not even mention the bronchodilator responsiveness test.
Yes, sir. But there are a lot of patients, and even I get confused sometimes. The reversibility, like earlier, we used to see the reversibility.
This myth, I would call, is so deeply ingrained in our minds that we tend to make a diagnosis of COPD with no response and asthma, but we should be clear that this test has been given up as a diagnostic test. So that is very, very important. History, that is the most important way. So, Dr. Saraf, you...
Yes, sir. So I want to ask a question regarding in the clinical practice, sir. Whenever we, in case of moderate to severe COPD, if we are getting a good bronchodilator response, and they are on the treatment on LABA/LAMA we give. So should we use ICS if we are not considering the eosinophil thing? Should we use ICS in those patients who we know by history that they are COPD and we are getting a good response? Should we use ICS in that patient so that
the guidelines are very clear when we have to use ICS? One is the eosinophil criteria. Second is that there has to be an asthma kind of history in the patient. If there is wheezing, patient getting up at night, there is seasonal variation, he gets symptoms when exposed to dust or irritants, then there is justification, or there is a history of exacerbations. Otherwise, the bronchodilators are the drugs of choice. It's very paradoxical, what is the drug of choice for COPD? It's bronchodilators.
Yes, sir.
And we say that it's a drug, it's a disease which does not respond to bronchodilators. So that is why that old concept is gone, and we use steroids as and when indicated. And these are well-defined indications.
Sir, I would just like to add to his question. This response which we are seeing, the bronchodilator reversibility in COPD, it is actually not seen every time. So sometimes we see the acute response, but then sometimes when we repeat the spirometry, it is not seen.
It's not there.
So that is also suggestive that we are in the right direction and we are treating.
So that is why the test is
the serial spirometry and the
bronchodilator response test is not indicated in
COPD.
This is clearly COPD.
Yes.
Dr. Garg, what happens? Dr. Saraf, your question. I'm sorry. In pregnancy, use of spirometry.
So it is usually
Pregnancy
seen
with
that,
asthma.
that bronchial asthma may complicate around 4 to 8% of the pregnancy. So spirometry, it helps us to make a diagnosis of the bronchial asthma in case of pregnancy. It tells us the reversibility, the airway obstruction, to monitor the effectiveness of the treatment. And it also helps us to differentiate the asthma-related shortness of breath and the normal shortness of breath which is being experienced during the pregnancy.
Right.
So,
what is the impact of pregnancy on spirometry? And can we do it anytime in pregnancy? Anytime in pregnancy, can we do it?
Pardon, I didn't get you, sir.
Can we do it in first trimester, second trimester, third trimester in pregnancy?
So, spirometry is very much, it's without any complications in the first trimester as such. Though there are certain values which are being decreased during the pregnancy because of the abdominal pressures, that the FEV1, the FVC ratios, are, as well as the FEV1 by FVC ratio, may decrease a little during the pregnancy because of the abdominal pressures.
So third trimester results are sometimes difficult to interpret because the diaphragm has gone up and the lower part of lungs get compressed. So FVC reduces. So the ratio may falsely come out to be normal and may start appearing like a pseudo-restrictive pattern. So again, history remains very important, whether it is dyspnea because of physiological breathlessness in pregnancy or is it asthma. But whenever required, it can be safely used, especially first and trimester and second, especially at new onset asthma. Dr. Bobna, you want to come in?
Yes, sir. So basically, it's a relative contraindication pregnancy, basically. And it should not be done in the late pregnancy, the last trimester, as you said. Yes, sir.
So that is one of the relative contraindications which are given.
Yes.
So similarly, Dr. Garg, when a patient has an extreme obesity, then what is the impact on spirometry?
So we usually get a restrictive pattern in case of obesity. The FVC is reduced, though the patient might have a normal airflow. He doesn't have an obstruction.
Because there also the problem is whether the breathlessness is because of asthma or is it because of obesity. So that differentiation is very important. Spirometry may give a falsely normal ratio and reduce FVC, looking more like a restrictive pattern. So again, history and examination, that remains very important. And obesity has another impact on asthma, that it is one of the factors for more severe asthma.
Yes.
So that also complicates management sometimes. So you may require more than once spirometry, therapeutic response to inhaled steroids, and repeated responses to bronchodilators. So Dr. Ahluwalia, ABPA is another special situation. So is there any well-defined role for spirometry in management of ABPA?
Sir, although spirometry is not included in the guidelines for diagnosing or assessing the ABPA functions, but spirometry can be used in adjunct to the other diagnostic tests and the clinical evaluations of patients suffering from ABPA. It can help us in assessing the airway obstruction, also to see the bronchodilator response, and also to look upon the acute or chronic exacerbation. As in ABPA, we see there is a lot of airway inflammation and also airway remodeling because of the baseline disease.
Right. So per se, the criteria for ABPA, since they are asthmatics, so as far as the application in asthma is there, so spirometry has its role there, that you have to establish the diagnosis, and assess the degree of obstruction and
Yes.
start the approach, because these patients, besides requiring treatment for ABPA, also require treatment for asthma, the appropriate
Yes, sir.
steps. So, Dr. Bopna, what about acute severe asthma? You did mention that in the beginning. So, when we would do in acute severe asthma?
So basically, exacerbation is the change in the symptoms and the lung functions from the patient's usual status. So lung functions are, the airflow limitation is measured with the FEV1 and peak expiratory flows from the predicted values, and they're compared with the predicted values. So in the poor perceivers of the symptoms, like you said in the earlier session also, so when the patients are not complaining of any symptoms and you hear wheezing on the clinical examination, then you do a lung function test and you see that the patient's lung functions have fallen, and so it helps us in avoiding the under treatment and overestimation of the control of the symptoms, and that's why lung functions are basically it helps us in it is a more reliable indicator in basically telling us about the severity of the exacerbation.
Especially if the patient is coming for the first time. If the patient is already a known asthmatic, then if the clinical state allows, one may. Otherwise, the kind of cooperation that is required for spirometry, that may not be possible if the patient is acutely dyspneic. So it's all a clinical judgment and stabilization.
I mean, yes, for sure.
After the patient has recovered and then follows up in the OPD, then we can reassess the patient, and there maybe a spirometry can be useful. So I'm running out of questions now. Let us see if there are questions from our audience. Actually, there are some questions on lung function testing in general, which was not the focus of discussion, like people asking about how to grade restriction and DLC. So that is outside. So our discussion was more on asthma than on lung function testing per se. No? In your clinical practice, what percentage of patients have classical findings of bronchial asthma on spirometry? Dr. Bubna, you would like to take this? In your clinical practice, what percentage of patients have classical findings of bronchial asthma on spirometry?
I would say, excluding the severe asthmatics, 95%, if they are not severe asthmatics, 95% have the classical asthma finding and the variability, which is 12% and 200 ml. And many a times the variability is excess, which is 14% and 400 ml also. So if we...
most of the patients have these classical findings. And that is what the definition of asthma is. History plus documentation of variation in airflow limitation.
But sometimes the FEV1 by FEC can be normal also in asthmatics. So we have to be...
We have discussed that there can be period of remission and excessive. So it's a dynamic condition. It will fluctuate. How frequently should bronchodilators be stopped? So this we have discussed already, that there is no need to stop bronchodilators once the diagnosis is established. So patients can just take their morning doses and come. Then there is a question on Dr. Alu Alia. How to correlate lower limit of normal and 80% predicted?
So, sir, in the earlier days, we used to stick towards the predicted less than 80% values. But now in the recent guidelines also, now we are following lower values than the lower limit of normal. Right. So there are various factors which we have already discussed, which the values depend on.
Right.
For the lower limits of a particular
so we have to pick up our predicted values correctly, and new software of spirometry. Now they give LLN as well as Z scores, and we need to get used. So I had an editorial in Lung India just a couple of months back where I explained what is the Z score and the lower limit of normal.
So can I just add to that?
Yes.
Just to clarify, because there is a lot of, because it's a new addition as
Yes.
per the ATS ERS.
Yeah.
Let us just emphasize on this. So basically, the new ATS ERS Technical Standards Committee recommendation as per 2021 uses instead of the predicted values, they use the Z scores. So as we discussed, the predicted value is basically only the 50th percentile.
Yes.
And any standard deviations from the predicted value, up till the minus 1.645, which is the lower limit of the normal, which is taken as a Z score. So you should always see the Z scores. If the Z score is below minus 1.645, that is abnormal. Now, if you want to see the severity, then you check the Z score. So there are three numbers basically which we need to remember. Mild, moderate, severe is basically mild is minus 1.65 to minus 2.5. Moderate is anywhere below minus 2.5 to minus 4, and severe asthma is basically minus 4.
So we pulmonologists have got to get used to these mathematical concepts. In fact, in the editorial that I am talking about, there is a table which mentions this grading of Z score.
Yes.
So, Dr. Garg, any difference between slow vital capacity and forced vital capacity in asthma?
So actually, sir, they both may vary, but the forced vital capacity generally indicates more of the smaller airways or
actually, normally we don't do the SVC maneuver in spirometry, but we do the SVC maneuver when we do the lung volume estimation.
Yes.
And FVC and SVC difference, that indicates a degree of air trapping. In more severe asthmatics, the SVC is longer. See, what happens in forced vital capacity is that there is a dynamic compression of the airways, so there is air trapping. In slow vital capacity, there is no forced compression of the airways, so a person is able to exhale out more volume.
Yes.
So the SVC is more than FVC in severe asthma, but SVC we do only when we do the lung volume estimation.
So actually, they say that we should do FEV1 by FVC, which is a more reliable predictor in COPD than FEV1.
Yes, but then you have to do the two maneuvers.
Lung volume.
Yes.
Yes. So bronchodilator response we have discussed in detail. So, and I think we are also past our closing time. So most of the questions actually AVPA. So we have addressed all the clinical issues, I think, and it was a very interesting discussion and a good learning experience for me also, and this excellent panel of Dr. Saraf, Dr. Garg, Dr. Ahluwalia, Dr. Bubna. They have enriched the discussion, and I am sure that the clinical aspects that we have discussed, the audience would have benefited from this discussion, and this will help in our clinical practice. So a very satisfying evening with all the panelists, and I must thank all the panelists for their great inputs and interventions. And I would like to just invite one-liner comments to close. So Dr. Saraf, anything you want to add about using spirometry in asthma?
So we have to be history is always the main thing. So we have to be very careful while taking the history of the patient. Spirometry always aided to the diagnosis, but the main thing is the history.
Right. So as you rightly say, the clinician remains the king. Your knowledge of history and clinical judgment analysis, that is very important, and spirometry is as an aid. So then you are through. So Dr. Garg, final comments from you?
Yes, sir. As we know, it is clearly mentioned during the step up, we don't require spirometry, and during step down, we might do a spirometry. So we can say whenever the patient is doing better, so we should do a spirometry. That would be done.
So we should judiciously use spirometry to our advantage and avoid unnecessary testing of these patients. So Dr. Ahluwalia, closing comments from you?
So I think, sir, my takeaway from this webinar was that we should always keep a very close follow-up in form of any serial spirometry, and also put a lot of focus on personal best of each patient. so that there is an individualized treatment to all the patients.
Right. So again, a very important observation that spirometry variation and range we must be aware of, so that we don't make errors in our diagnosis.
Yes.
And that range comes from the right choice of prediction equations. So that is
Yes.
extremely important on doing spirometry. And Dr. Bobna, final comments from you?
Yes, sir. So everybody has covered everything, but I would like to use your talk in the last minute, last liner. Basically, when you buy the spirometer, you should know which spirometer you are buying, the flow-based or the volume-based. Then the quality assurance is most important. The filter should be used to prevent the infection. And, the technician should be trained enough. The acceptability, repeatability criteria should be matched. Then the interpretation, we should also learn how to interpret spirometry. So the more spirometries we keep doing, we get used to all those 15 parameters and we can adapt and use them in our clinical practice. So I would say quality assurance is most important.
Very well said. So that way I always say that spirometry looks easy, but good spirometry is difficult. And good spirometry is what we should always strive. So before I end, I would be not doing my duty if I don't thank our persons from the CCI, Dr. Vijay, ever so enthusiastic about organizing these seminars. Then our leader, Dr. Krishna, who has been the inspiring light for these webinars. And I'm sure these will keep on indefinitely like this, and we'll keep learning. And Dr. Nayana it was a pleasure to have him with us just for the brief period. So all in all, a very interesting evening, and I'm thankful to the sponsors, CIPLA, for providing their logistic support. So with this, I think I would close this session.
I would like to thank you for moderating the session so nicely. And, we actually discussed all the clinical applications of spirometry. So thoroughly covered by you, very well put up questions for everybody, actually, people in practice and people who are starting their practice. So really enjoyed today's session. And thank you so much, sir. I would also like to thank Dr. Krishna, Dr. Pradeep, and Dr. Vijay Kumar Chandran Chetty for giving me the opportunity.
All right, so
I
think everybody goes satisfied with the experience. So lovely evening.
Yes.
So thank you, everyone.
Thank you, sir.
In future again, right?